Truncus arteriosus. Truncus arteriosus, or the common arterial trunk, accounts for 0.4 to 4% of all congenital heart defects. It involves a single vascular trunk arising from the heart and includes the aorta, pulmonary arteries, and the coronary arteries. And this cyanotic defect, whereby mixing of the blood occurs at the numerous level within the heart. In addition, the common ventricular atrial septum, the mixed blood flows through the common truncal valve and subsequently to the body, lungs, and the coronary arteries, depending on the relative resistance of each vascular bed. By the end of the fifth week, the normal development, the aorta and the pulmonary artery have formed from the single truncal root. A septum spirals and separate into the two great vessels. The truncus arteriosus results from failure of the septation, and as a part of the separate aortic and pulmonary valve cannot form from a single truncal valve in the proximal portion of the common trunk. The outlet ventricular septum is also formed by a part of the normal truncal septation. As a result, the VSDs are almost always associated with truncus arteriosus. Truncus arteriosus as well as interrupted arch have been associated with both deletion of CDC4 a protein involved in the neural crest migration, and the microdeletion of the chromosome 20q11, which is also associated with DiGeorge syndrome, and maternal diabetes. Smoking has also been associated. And these are the steps of the formation of the primitive ventricle. Truncus arteriosus can be classified by several systems, and one classification, call it adverse, in which the type 1, the branch P arises from the P of the common trunk. Branch 2, P arises from close proximity of the proximal common trunk. Branch 3, the P arises from a separate, widely spaced origin, and the absent branch PAs and the aortopulmonary collaterals PAs arise from descending aorta. And when Prague classification, AB1 is the branch P arises from the main P of the common trunk. Branch P arises from the separate from the trunk and wide or closely spaced, and the unilateral pulmonary atresia is the AB3 with collateral supply to the affected lung, and AB4 is the truncus arteriosus with interrupted or hyperplastic arch or a coarctation is there. So in the single truncal valve, it could be trileaflet, and the quadricuspid or bicuspid, the leaflets are generally thickened and malformed, and the valvular regeneration is present. A VSD is almost always present and usually of large size and non-restrictive. The aortic arch anomalies are common and include the right arch, interrupted arch, or a hypoplastic arch. TA, the patient with the arch anomalies have the pulmonary dominant TA, and there are ductal dependent lesions with the essential PDA providing the flow to the descending aorta. The other associated anomalies including a PFO, ASD, persistent left SVC, and the tricuspid or mitral anomalies. The coronary artery anomalies are frequent, and the LAD is often small and can arise from the RCA and alter the surgical planning of the right ventriculotomy, and the RV infundibulum can also be supplied by large conal branches of the RCA. The left coronary can have a high origin or arise from the pulmonary arteries. The coronary ostial anomalies, including the location anomalies and the ostial stenosis, occurs in up to 50% of the patient. The deoxygenated and the oxygenated mix at the level of the ASD and the VSD and truncus during the systole and asystole leads to cyanosis, and the degree of which depends on the balance between the pulmonary and systemic blood flow. Pulmonary and vascular resistance is high in the newborns, with the truncus arteriosus restricting the pulmonary blood flow and leading to a smaller degree of the left to right shunting at birth. As a result of cyanosis is more pronounced, a PVR drops over the first few weeks of life, and increased left to right shunting leads to the reduction of the degree of the cyanosis and increased pulmonary blood flow, and the clinical signs of the heart failure due to increased pulmonary volume and reduced systemic cardiac output. The heart failure typically presents in the early Truncus arteriosus because of combination of the proximal takeoff of the pulmonary arteries and the high diastolic pressures in the great vessels and the shunting that occurs throughout the cardiac cycles. With a regurgitant truncal valve, additional volume overload is forced into the ventricles and can worsen the heart failure. The truncal regurgitation can cause the ventricular dysfunction by lowering the diastolic blood pressure and increasing the ventricular volume and thus decreasing the coronary perfusion and increasing the myocardial oxygen demand. Less commonly, the truncal stenosis can lead to myocardial oxygen demand and increasing the afterload and decreasing the coronary perfusion. Neonates with truncal arteriosus present with mild cyanosis, heart failure, and sometimes a murmur. Heart failure can present in neonates with poor feeding and lethargy. Respiratory distress, tachypnea, and diaphoresis, hepatomegaly can be seen, and a pansystolic murmur is usually appreciated, and a diastolic murmur can be appreciated if there is significant truncal valve insufficiency. The symptoms depend on the PVR and the balance between the systemic and pulmonary blood flow. The heart failure can be exacerbated by the truncal insufficiency and interrupted arch. Initially, the symptoms may be mild, but when PVR decreases, the pulmonary blood flow increases and the heart flow worsens. If left uncorrected, irreversible pulmonary vascular obstructive disease can develop as early as 6 months, and if this occurs, the survival is very low, with a few surviving beyond 1 year. Chest X-ray may show cardiomegaly and increased pulmonary vascular markings. The arch is rightward and in quarter of the patient, so the combination of the right arch and increased pulmonary vascular marking is strongly suggestive of truncus arteriosus. The ECG will demonstrate a biventricular hypertrophy. Fetal echocardiography can sometimes diagnose truncus arteriosus by locating the pulmonary artery origins from the ascending truncus. The postnatal echocardiography is method of choice for diagnosis. A parasternal long axis view shows the large truncal valve overriding the VSD, and the suprasternal views can delineate the arch and the pulmonary artery anatomy. Cardiac MRI and catheterization are rarely used for diagnosis, and the sole role of catheterization would be to evaluate for reversibility of the PVR in patients with delayed diagnosis. So medical optimization and stabilization before surgery is critical by managing the volume status and the inotropic function. The PDA in patients with interrupted arch or coarctation must be maintained, as closure leads to decreased distal perfusion and greater heart failure risk as afterload increases. In past, the initial palliative PA banding was used to restrict the pulmonary over circulation and allow the infant to grow, deferring complete repair, and this however requires two operations and subject of the infant of the potential complications such as the band migration, the PA distortion, and the need for the reoperative sternotomy. In addition, the PA banding has not been shown to be affected with the long-term outcomes or prevent the pulmonary vascular obstructive disease. The neonatal primary surgical repair is now the preferred treatment for the truncus arteriosus. The surgical repair should be performed during the neonatal period and expected 1 year survival of more than 80%. The primary surgical repair has been three major goals: separation of the PA and the truncal root and the VSD closure, and the RVOT reconstruction utilizing the conduit. Primary repair is achieved by median sternotomy and a full flown bypass with a moderate hypothermia. Deep hypothermia with the circulatory arrest may be necessary for more complicated type of TA requiring arch repairs. The distal ascending aortic cannulation is always performed at the base of a nominate, and the bicaval cannulation is used with an LV vent through the right superior pulmonary vein. The PAs are mobilized and snared immediately about institution of bypass so that the systemic flow is preserved. The cardioplagia can be given antegrade or retrograde in cases of significant truncal regurgitation. The truncus should be cross-clamped as distally as possible. To repair the truncus arteriosus without the arch abnormality, the PA are removed in a button fashion from the truncus, and the truncal defects is repaired with or without patch. The direct coronary assessment is imperative to avoid damage, and a right ventriculotomy is performed as a avascular portion of RVOT. Patch closure of VSD through the right ventriculotomy is done. and ASD or PFO can be closed through the right atriotomy. Consideration should be given to leave the PFO as pop-off for the RV dysfunction and anticipated postoperative spikes of PVR. The RVOT is reconstructed using a pulmonary aortic allograft and the bovine jugular vein graft or heterograft valve conduit. Distally, the graft is sewn into the confluence of the native branch PA and the proximal aspect is sewn to the right ventriculotomy. The proximal anastomosis of the conduit can be augmented with a hood of a valvular competency and would be compromised with the circumferential primary anastomosis. The patient with a TA interrupted arch additional aortic cannulation is performed at the ductus arteriosus for distal perfusion with deep hypothermia to 18 degrees, and after the adequate cooling and circulatory arrest is initiated, the regional cerebral perfusion can be employed by cannulating a tube graft sewn into the innominate artery or by advancing the ascending aortic cannulation into the innominate artery. After ligating the ductus, the back wall of the distal ascending and the proximal descending aorta are approximated and the arch reconstruction is performed. The aorta can be recannulated and de-aired and cross-clamped with subsequent return to full-flown bypass of temperature. Standard truncus arteriosus repairs follows as usual, and the truncus insufficiency or the uncommon stenosis often proves after the primary surgical repair of the TA and decrease in volume overload. Gradients less than 30 millimeters usually do not require intervention, and repair of moderately increased truncal insufficiency ought to the delay, as there is a significant increase in mortality for the truncal valve replacement with the TA repair. Patients with severe truncal insufficiency often do not have to survive, while a moderate to severe truncal regurgitation associated with the lateral valve and reintervention without increased mortality, and if the truncal valve intervention is performed, repair is preferred by resecting, repairing, and resuspending the cusp. Outcome as well as the operative techniques vary based on the anatomic subtypes of truncus arteriosus. The overall perioperative mortality is around 11% and amongst all subtypes, and long-term survival of all subtypes and the surgical repair is 90% and 85%, 83% in 5, 10, and 15 years respectively. The major determinants of the mid and long-term survival after complete repair of truncus arteriosus are the degree of the truncal valve insufficiency and the failure rate in the RVPA conduit, as both of these require re-intervention. Thank you very much.